for the Central South Stroke Network. This year, our theme is Patient and Family Education, and today's topic is Foundation of Goals of Care Conversations, and it's the first of a two-part workshop, and the conclusion will be 1 week from today, January 30th. And just as we offered it today, it will be at 11 and at 2 p.m., the same webinar. Okay, the registration link will be in the chat a little bit later, and you can certainly register for the second part if you have not. And as well, you can register for the upcoming webinars in our series. So please submit your questions in the Q&A at any time. There'll be opportunity to have questions answered throughout the session and at the end. So I'd like to introduce I'd like to introduce Sandra Anderchuk. Sandra has focused her professional career on health, wellness, and caring for those who have been impacted by illness. Sandra holds a master's degree in science, nursing from McMaster University, and a master's degree in health science, bioethics from the University of Toronto. Sandra has had an extensive career in healthcare, serving 16 years as a pediatric nurse practitioner and over 10 years as a healthcare ethicist. Sandra's career has focused on supporting patients, families, and the community with end-of-life care planning, educating and supporting healthcare professionals on caring with compassion for the dying patient, assisting clients to navigate the moral, ethical, legal, and technical landscape within the Ontario public and private health system. Sandra offers community and professional education on advanced care planning, goals of care in serious illness conversations, aging well, and death and dying. Sandra is a master trainer in the Serious Illness Care Program and is project lead for end-of-life care planning at Hamilton Health Sciences. Sandra is also a certified yoga instructor, providing senior yoga classes aimed at improving health and wellness as we age. And with that, I'll turn it over to Sandra.
Okay, great. Thanks so much, Tina. So welcome everyone for coming today. And thank you so much for taking time out of your, I know, very busy days and being part of this webinar with us today. So as Tina has introduced, I am going to talk about the foundations of goals of care conversations this week. And then we're going to follow that with end-of-life care planning for next week. So really for this week's session, I'm hoping that you have an opportunity to learn more about identifying the right conversation at the right time. There's multiple conversations that happen in our health system, and so we want to get the right conversation with the right person at the right time. And also we want to make sure we're talking to the right person. So I'm going to talk to you a little bit about the substitute decision maker and how to identify that person. I'm going to offer you a framework for goals of care planning. I'm also going to talk about some of the barriers to goals of care planning and strategies to overcome these barriers. And we're going to talk a little bit about how to approach the conversation around code status and CPR. So before we begin, we've got a couple poll questions here for you. So the first question, how comfortable are you with goals of care planning? So we've got a few options: extremely comfortable, somewhat comfortable, I could use a bit of coaching, and help, I have no idea how to approach these conversations. So I'll give you guys a couple more moments to answer. So it looks like it's neck and neck here between somewhat and I need a little bit of coaching. Okay, so it looks like it's sort of a little bit of variety here between each of the different categories. So a little bit of coaching, somewhat comfortable for most of you. Some of you are feeling quite confident, and there's a few of you that could really use some assistance, and you're not alone, because many people talk about feeling incapable or needing more capacity to have these discussions. So hopefully everyone will take a little bit from this discussion today. All right, so our next question. All right, So how do you approach goals of care planning? So I usually allow the conversation to develop organically. I have a systematic approach that I use. I leave it up to others to do the planning, or reactive is my middle name, meaning that you just respond after the planning's done. All right. Okay. So we've got about 22 responses here out of about 29 that are participants. It looks like the majority of you allow it to evolve organically, which is a common way in which we enter into these discussions. And I might change your mind on that a little bit, or you may realize that you do a lot of planning before you actually enter into these conversations. So, so thanks for participating in that poll. It's kind of helpful to know sort of a baseline of where people are coming from and what you think about planning and goals of care. So I always like to share this framework with folks because I think it sheds a little bit of light on how we progress from one type of form of conversation into another and how that changes depending on our situation. So the first is the advanced care planning conversation. So many of you may have heard of this term, ACP, advanced care planning. And Health Canada recommends that every person over the age of 18 engage in some form of formal advanced care planning. So again, many of us as health professionals, we've shared with our families just based on our experience, the things that we'd want or not want. And sometimes it's, off the cuff or during a casual conversation. But advanced care planning is actually sitting down and really giving some thought to things that are most important to us, what we wish, what we value, what we'd be willing to live with, what we wouldn't be. And one of the key portions of ACP planning is identifying the right person to make a decision for you. And I'm going to talk a little bit more about what that looks like. So that's a key point in all of this. People often do advanced care planning when they start doing their estate planning or when they do funeral planning or financial planning. Somebody tips them off to say, well, have you thought about your health planning as well? So it falls into that whole bracket of planning for our future needs. The idea of goals of care discussions or goals of care planning. You may be surprised to know that every single person that enters into a health institution, whether it be a community clinic or into a hospital acute care setting, will have a goals of care discussion because you're coming in with an issue and we need to understand what it is you want to achieve from the health system in order to accomplish your goals. And so you set out by, and I give the example of even on the maternity floor, you may be coming in to give birth to your child and you want to have a natural birth, or you want to make sure you're pain-free, or you want to do, go from having a previous C-section to a vaginal birth. So those are things that you are setting as your goal. And then the health professionals are gathering around saying, okay, if that's your goal, here's the things that we can do to help you achieve that goal. So the same thing happens in cancer care, cardiology, stroke care. So multiple areas have the team gather around when the person has determined what their goals are. Sometimes though, people need support in understanding what goals are achievable. Okay, so that's when we start to have further conversation about what the person wants for themselves and what we can actually offer to help support those goals. The next type of conversation is the serious illness conversation. So this is a conversation that leads into the planning for end of life. And so patients often trigger this conversation because we can use the surprise question. Would you be surprised and if this person was to die in the next year? And your answer may be no. And that's when you need to start thinking about, okay, we've had the goals of care conversation. We know what they want, but let's talk more about what they value, what's important to them, what they're fearful of, what they're worried about, how we can start supporting them to ensure that they have a realistic picture of their disease, and they also have the opportunity to do the things that they want. So that conversation looks much different than the goals of care conversation, which is a more medicalized type of conversation, talking about interventions and treatment. And then the last conversation, which kind of gets muddled in somewhere with all of these. So even with advanced care planning, you might be talking about the code status and whether you'd want CPR. With the goals of care, we often pull in code status. And even sometimes when we talk about end-of-life planning, that's something that will come up because, of course, the person knows they're heading towards death, and that's just sort of that organic way of this conversation coming up, which is your code status. And so in the code status conversation, it really is getting clear on the prognosis. It's also getting clear on what would be the typical approach if for that person with the particular illness that they have, whether or not CPR would be appropriate. And then also the pros and cons of that. So what would happen after the resuscitation? So there's a lot of detail that often goes into the CPR conversation that really should be a conversation that's carved out just for that, versus muddling it with the other discussions that we're having, because we don't want to lose all the important points of all the other discussions, although it kind of ends up being embedded there often. So this is just another way to show you that graph. So as you can see, everyone should be having an advanced care planning conversation. Many people end up needing some support from the health system. So there's your goals of care, and those goals of care can be medical, surgical, nursing, rehabilitation, pharmaceutical. So many different health professions help develop those goals of care for the patient. Or with the patient. And then the serious illness, again, when the patient is triggering that discussion. And then the code status, less people are having that discussion around code status. So you can see from the graph just the little diagram of the number of people there. So shifting gears a little bit. So we're going to have the conversation, but who should we be having it with? So many of you may be familiar with the Healthcare Consent Act. Less of you probably have read it from cover to cover because it's quite a long document. There is one section in the document that's section 20 that deals with specifically incapable patients. So how to make decisions, how to care for people who cannot direct their own care. And one of the very first things we have to identify is who is the right person, or who will be the person making decisions for them, because that's who you want to be talking to. And I'm sure you've all done it where you've had this long, great conversation with a member of the family member, and then they turn to you and say, well, you're going to have that discussion with my sister because she's actually the one that's appointed as the power of attorney. So you kind of want to get it right for yourself, but also for the patient at the very beginning. When we are doing our estate planning, we go to our lawyer and we talk about our powers of attorney. There's a power of attorney for property and there's a power of attorney for personal care. Those are two different people, can be held by the same person. But that's when somebody would typically appoint a power of attorney for personal care. So if I decided I wanted my brother to be my power of attorney, then he would then trump anybody else. Except with the exception of if a judge came in and said, you're not doing a good job, I'm going to appoint somebody else. I'm going to use my legal authority to appoint a guardian. So then that would be somebody who would trump a power of attorney that I appointed. But technically, that person is the person that I choose. So I may say they're a good communicator, they know the health system, they can advocate, they have the same values as mine, they'll uphold my values, and they'd be a good person to make decisions for me. If I don't appoint somebody and I just leave it to chance, then it's going to go by the ranking system. So it might be a spouse or partner, which would be the top ranking. Could be parents or children. And just keeping in mind, if I'm a 40-year-old and I have two capable parents that are in their, let's say, 70s, and my children are above 18, let's say they're 20 and 22, all of them are capable. That means all of them have equal rights to make decisions on my behalf. Unless somebody recuses themselves, they would be able to weigh in on the decision. So we all know that when you're dealing with multiple people, the decision-making becomes much more complex. So it's so much easier from a health professional perspective, but also from the perspective of the family, that we're not having to all come together and come up with the same agreed decision. And so it really is helpful when we look at appointing one or maybe two people, but not, all five of our children. And this applies for all of us, right? Not just our patients, but for us too. And then the rest of the green is family members, so any relative of the person. And then if failing that, it's the public guardian and trustee. So everyone in Ontario has a decision maker, even if it ends up being the PGT. So we have to get clear on who that person is. So, okay, so we know who the right person is. Now, how do we go about even entering into discussions? And, oftentimes the goal is obvious. Okay, so somebody comes in with a heart attack. Our goal is to stabilize them, right? So we don't necessarily need to be saying, do you want us to stabilize you? They're assenting by coming into the emerge. But when we really want to sit down and have a clear discussion, when there's multiple options that might be available, and we need to get clear on where we're headed. So we want to find that North Star. That North Star is what the patient describes as what they want for themselves. And how do we as health professionals then help them achieve that? So the first thing we need to get clear on is what's going on. So we need to be looking at the diagnostic studies, the blood work. We're doing our physical health exam. We're gathering our data. Okay, so we're getting a real, true, clear picture of what's going on with this person. We're then also, the other data that we're gathering is, what does the person want? What have they said in the past? If they can't speak to us right now, we need to talk to their substitute decision maker about understanding what their wishes, their values, and their beliefs are. Those are the two main things that help us make health decisions. So in the Healthcare Consent Act, it says that you are to gather information on the patient's wishes, values, and beliefs, and in collaboration with the standard of practice and evidence-based medicine in order to make an informed, appropriate decision for that person. So the patient wishes, they might be advanced directives. In the US, they call them living wills. We call them advanced directives here. Advanced care planning material that somebody may have walked through that process of advanced care planning. There's lots of workbooks that people may have filled out. In general conversation, they may have described some of their wishes to their loved ones. The Healthcare Consent Act also says it's the last express capable wish, whether it be verbal or written, that's applicable to the situation that is to be upheld. Okay, so say somebody may have a wish, have something documented that the healthcare team doesn't agree with. They may feel like, I wouldn't do that in this situation, or I would definitely want this in this situation. I don't understand why they don't want that. So their voice weighs heavily as long as it's applicable to the situation. So, we can't be, asking to be frozen until there's a cure for cancer. So that's just not reasonable. It's not applicable because it's not available for that person. So it is within reasonability that it would be applicable to the situation. So now we have these two things. Now we're going to look at, okay, so we know what the prognosis is. We know what's going on with the person. We know what they want. Well, what do we have to offer them that is based on facts, on science, on evidence? And so we gather that evidence that we have, that best standard practice. And also, we do have a responsibility as health professionals to gather information from our experience too. So experience is another important element of helping guide some of the options of care that are available to the patient. And then once we have that, we then go through an informed consent process. So that means sitting down with the patient, with the SDM, and looking at the risks, the benefits, the options, the alternatives, what happens if the patient doesn't accept the treatment that's recommended. So describing what that might look like for them, and then coming up with a decision. And once we then set our goals, and it might be 1, it might be 3, it might be 5 goals. And then as a healthcare team, we all start to participate in managing and helping support those goals. So that's the process that one would go through. And I recognize that there's sometimes we have to make quick decisions about goals, but if we wanted to go through a framework and a process, this would be the best way to go about it, so that in the end, we're following what the patient wants. We're using our knowledge about about the disease and what's applicable and available to that person. And all along, we're also communicating. So we're working as a team, we're communicating with each other, we're communicating with the family and with the patient. And communication for a patient that is not able to speak to us. So we often think of communication as being verbally able to communicate. And as you know, in the stroke population, that tends to be a problem. And so we need to be calling upon our SLP colleagues to say, hey, is there anything that you can do to support communication, a visual assisted device or communication board or something that can help us understand what this person would want. So very, very key role in all of this to be able to support the patient in articulating their wishes. So informed consent is a process that requires all the right information. So the informed consent process, again, this is stated in our Healthcare Consent Act that this is something that is required in order for consent to be either provided or withheld. So sometimes it's important to also say to somebody, if you don't want this treatment, we also need you to consent to either withdraw or a consent of refusal. And on our consent forms, there often is a back page that says, having the substitute decision maker sign to say that they're refusing the treatment options that have been offered. So important to go through the risks, the benefits, the alternatives, which would be considered the options, and then what would it mean not to have the treatment. And the person has to voluntarily participate. And by that, I'm also meaning the substitute decision maker has to voluntarily participate in that conversation. They have to be capable and able to make that decision. As health professionals, when we're proposing treatment, we're assessing the capacity of the person who is signing consent. So whether that be the substitute decision maker or the patient, do they understand and appreciate the information that we're providing to them? So this whole idea of healthcare planning is a group effort. It's a team sport. We all have to participate, and there's lots of information that we need to share with one another. So for example, if a physician's ordering, let's say, for example, a type of diet, and the dietitian says, I did a swallow study and the person can't swallow, and we need to do this type of diet, then we're working together in our various assessments, in our various skills, and in our roles to be able to come up with the best plan that's going to meet the goals of care for that person. I always put this in because I live with a carpenter. So measure twice, cut once, which means, I'm sure it's obvious, but the more planning we do, the more likely it's going to be successful. And sometimes you don't have a second chance to go back and do it again. And so you want to make sure you get it right the first time. So I'm going to share a story with you. So this is an actual story that I've taken out the identifiers, obviously, but this is a case that I was involved in when I was bioethicist. It was on a stroke floor. So Marita is a 76-year-old widow. Her husband died 6 years ago of a stroke himself. She was healthy. She had no prior history of illness. She was, golfing, and she was volunteering. She was the primary caregiver for her grandchildren. She started to experience symptoms, very subtle symptoms, before having a hemorrhagic stroke. So she came into hospital. She had moderate level 2 dysphagia. She had ongoing weight loss and microaspirations impeding her potential for rehabilitation. She just didn't have the energy. She wasn't gaining in leaps and bounds. So the nutrition aspect was a real big problem here. And the team was recommending that she have a temporary feeding tube in order for her to maintain her nutritional status. She was also being given a TPN in the meantime because she was having a real challenge with swallowing her food. So from Marita's perspective, she did say to her son, after everything that happened with her husband, I don't want any heroics, I don't want any feeding tubes, and I don't want any resuscitation. So her direction was a bit vague, but those were the key points that she had said to her son. So her son, feeling like he was in quite a difficult situation, he was just hopeful that mom would regain her swallowing and she would make a full recovery and he wouldn't have to make this decision at all. The son was avoiding the team and the team family meetings to discuss the goals of care. He was angry that the nurses weren't trying harder to feed his mom, and he was refusing to talk about any alternative feeding plan. The physician was quite frustrated because he felt that this was the one option in order for Marita to regain her energy and was a good bridge from illness to recovery. The social worker had built a great rapport with the son, and she was concerned with mistrust of the family. Nursing were frustrated that the patient was constantly pulling out the IV, but they didn't feel comfortable in using physical restraints. And the SLP and dietitian, so our speech language pathologist and our dietitian, were concerned that the family was misinformed of the purpose of the feeding tube and diet, which was most suitable for her stage of dysphagia. So we're going to send you to breakout rooms, and we're going to let you talk about this case. It may sound familiar to you. You may have experienced this case in your own practice or something similar to this idea of making good plans around nutrition for a patient. So if somebody would like to snap a picture of this, of the questions, because when we send you into your breakout rooms, we may not be able to post it on the chat. So if you'd like to take a picture of that, and then we're going to send you into breakout rooms for about 10 minutes and then bring you back after that. And we'll talk a little bit about the barriers and strategies to overcome barriers. Okay, so welcome back, everyone. I hope you had a good discussion with your colleagues and that everyone had an opportunity to sort of contribute to what you thought might be going on, what some of the barriers might be, and also, you know, how you would go about entering into a discussion with this patient and their substitute decision maker, who was the son. I'll just give you the final outcome of this case. In this situation, the SLP and the dietitian were so pivotal in helping the son understand the difference between a temporary feeding tube and a permanent feeding tube. And with that discussion, the son then started mulling it over in his mind and thinking, well, actually, I think my mom meant more of a permanent, because she was continued to refer to her husband who had a permanent feeding tube and everything that he had gone through. And so with that, he then consented to the temporary feeding tube. And if you join us next week, you'll find out what the further results of her course of hospitalization was like. So yeah, so that was sort of the outcome, and the team did come together and create a great plan of care for all the different aspects of her care needs with the son. So some of the common barriers that we do find in creating goals of care are when patients come with a lack of express wish. So families will often say, I have no idea what my loved one would want in this situation. And when that's the case, people often will just defer to saying, just do everything, absolutely everything you can. That person may have wanted limits of care, but did not express them ahead of time. So coming with that lack of understanding of what the person would want. So again, going back to that idea of advanced care planning and identifying that person and having conversations with them ahead of time, whether it be, you know, through the advanced care planning process and documenting, or even if it's verbal conversation, so important. So I encourage all of you to do it yourself, and also to encourage your friend who can then encourage a friend, and then hopefully, you know, we spread the word. The other thing is unrealistic expectations of the healthcare system. And so sometimes illness and disease are not treatable, or we will never bring a person back to the state in which they were in before they entered into the hospital. And there is oftentimes an unrealistic expectation that the hospital system and the healthcare system can create miracles. And this is very challenging for health professionals who are seeing it through a scientific, realistic lens, when there's a lot of hopefulness of the patient and family. And so this can lead to barriers in not wanting to have discussion with one another, or not being able to meet the goals and achieve what the patient wants us to help them achieve. Sometimes there's physical barriers as well. So, I think it's particularly in stroke when somebody becomes aphasic or not able to speak. And so we do need to be thinking of other ways that we can hear their voice. So, looking at the communication aids, looking at assisted devices, the visual boards. So lots of different things, and innovative technology has been recently developed, which I'm probably talking to all of you who know all about this, but really trying to break down those barriers in order for a patient to be able to express what they want. And then, of course, also looking at the other communication tools that they've used, like advanced care planning, advanced directives, those forms of things that will help give guidance. For the family, there's often a loss of control. So they feel this loss of control. They feel like they have no voice. There's this feeling of being powerless in regards to decision making, particularly if the approach to setting goals of care is very paternalistic, where you're, as a health professional, just coming in and telling the person what you think they should do, instead of pausing and asking and gathering information about who that person is. So you often will be more successful if you build some form of rapport, and that can be quickly built simply by saying, tell me a little bit more about your mom and who she is. Outside of the hospital environment, tell me who she was before she entered into the hospital. That builds rapport very quickly, and it gives you a good understanding to then say, I'd like to recommend this. They also might have themselves trouble interpreting. So as you saw in Marita's case, her son had a difficult time interpreting what his mom really wanted for herself. And so he was taking it quite literally, what she was requesting. Also, there could be anger about recommendations and want better options. So that's something that, when the recommendation is for withdrawal of care, or that there's nothing further that we can do, so there's limited amounts of options available, it can create a lot of anger for people, and you have to expect that as well, right? So people will show emotion. People will be emotional in these situations where people have been devastated by an injury, particularly when it comes to a cognitive impact. There's also unrealistic expectations of the healthcare team. So again, in this case, the son was really expecting nursing to spend hours feeding mom, and it's just not realistic. It's just not. There's not the available time to provide that level of one-to-one care. So sometimes there's an unrealistic expectation of what the health professionals can do. And then there's also the concern around this idea that they're telling me this because they want the bed. And I know probably all of you have heard this at one time in your career, whether it be from a patient's family or from your own circle of family and friends who have experienced this, where people feel like, because in our health system, it's the right bed for the right person at the right time. Right. So we're constantly thinking about, is this the right bed for this person? This is an acute care bed. Should they be in a rehab bed? This is a rehab bed. Should they be discharged home? And so we're giving a lot of thought to where this person should be. Whereas from the public lens, it's often they just want the bed. And so this can create a lot of barriers to good care planning for that person, particularly when we know that environment may not be the best environment to improve and help that person meet their full potential. So this can be quite a challenge. From the clinical team, we know that, healthcare is not an easy profession to be in, no matter which profession you're in. There's often time constraints. We have to, get certain tasks done from morning to night, and they need to be completed, and often there's just not the time to sit down and have these long, detailed conversations with people, and so time constraints seems to be one of the biggest barriers in actually working through a thoughtful process of setting goals and having communication with families. It's also difficult to honor a patient's wish when you feel it might go against the standard of care. So again, back to this situation where the physician really felt like the thing that would help her the most would be to have a feeding tube put in place. But her wishes, according to her son, were, to oppose that recommendation, which created a lot of moral distress for the physician. So, and feeling like hands were tied because you knew what the right thing to do, what the right thing was to do, but you weren't given permission to do it. And so this can create a lot of difficulty in carrying out a plan of care without having the agreement from all parties, particularly the decision makers. And communication challenges with families. It might be avoidance. It might be multiple substitute decision makers. We've all been there when there's been, 4 family members trying to make a decision and they can't agree. And so it becomes very frustrating to move the needle forward when we're having to sit and do conflict resolution of the decision makers that have been either appointed or by default. And then high staff turnover. So we know that we come with our own opinions and experience on how things might be done. And there's often gray area, right? So even though we have a goal in mind, there might be different ways of getting to that goal. And so sometimes that will then deviate the plan away from the goal. So we know that there's often differences of opinions that happen when we have turnover of staff who are helping make decisions. And then the lack of skill in communication. I've had many people say to me, I just don't feel capable of having these discussions and I feel very uncomfortable. And so the tendency is to just not engage in the discussion or just tell the patient what is going to be done versus sitting down and working through that process of understanding what their wishes would be and how we can apply that to the situation given the options that we have available for them. So I've talked a lot about some of the barriers and some of the strategies as well as I was speaking. So just to kind of wrap it all up, to summarize kind of in 4 big pillars, the one first is planning is a process that takes all the right people involved. So it really is important that everyone who is helping care for that person is involved in providing information for decisions to be made. Doesn't mean that they're the final, like everyone has to have their say but it is often very helpful. And I gave the example of the dietitian and knowing the feeding and stuff, but also for, our therapists, right, who work day in and day out with patients and can really help guide some of the options that are available to the person by having worked with them and understanding what their activities of daily living are like. The next is that we need to understand the patient's wishes and values and what they want. We need to be able to give that person a voice because that's going to be what guides us, what they're asking for. And again, not to be confused with, I'm going to ask for everything. I'm going to want, unrealistic. I have unrealistic goals, but I want you to help me accomplish them. No, it's about understanding, what's most important to them, what they'd be willing to live with, what things would be so critical they can't even imagine living without, those sorts of things, which we're going to talk next week about serious illness, because those are some of the questions that come up in serious illness. Understanding determining best practice standards, options, and alternatives, right? So coming to the table with what we know on how to treat the disease. Really important that we try and come with an objective lens so that we're offering people treatment that that has been studied, that has been tested, that we know is sort of the gold standard approach, but then also using our own clinical judgment and understanding that we have gained from our experience. And then making recommendations based on patient wishes and best evidence. So bringing all those things together to make a recommendation on how we can achieve that goal. So, the 1, 2, 3, 4, 5 goals that we've set out, what are the options or what are the treatment options that we can put in place in the care plan to help meet those goals. So always having that as your North Star. So I'm going to do the next poll. So when do you think CPR should be discussed? So we're going to just end with a couple of comments about CPR. Okay, so far it's neck and neck, 50-50. Okay. So we've got about 60 to 70% of you responding, and the majority is on every admission with every patient. So none of those answers are wrong. It's just really deciding on when is the best time to engage in this conversation, because oftentimes we think we're just going to have this conversation with everyone, and then it doesn't become a valued conversation because we do it with everyone, and people just expect that when they come into hospital, they're going to be asked the question, and it's often not a lot of thought